today we shall start with the new chapter, that is Anti-Parkinsonian drugs. Coming to the outline of the chapter, we are going to see the classification of the anti-Parkinsonian drugs, then the individual drugs which include Levodopa, then Peripheral decarboxylase inhibitor, then comes the dopaminergic agonist, MAO-B inhibitors, COMT inhibitors, then dopamine facilitator, or it is also, or this particular class is also known as glutamate antagonist or NMDA receptor antagonist, and the last class is central anticholinergic drugs. Now before we start with the actual drugs under the anti-Parkinsonian drugs, just to revise about the disease, that is what exactly Parkinsonism is, or Parkinsonian disease as it is called as. Okay, so in Parkinson's disease, as you all have already studied under the pathophysiology of the central nervous system. Okay, so here there is an imbalance between the brain dopaminergic system and the cholinergic system. Okay, so dopaminergic system or the dopamine in the brain is depleted over here. Okay, so that causes the imbalance between these two systems, and there is precipitation of certain prominent symptoms. Okay, so the prominent symptoms or the prominent manifestations which are included under this particular condition is tremors. Okay, so light tremors may be precipitated, then rigidity, the person may not be able to move appropriately. Okay, so hypokinesia also is produced in this particular condition. That is, a person has problem with the movement, the motor functions are basically affected over here, so there is rigidity that the person may not be able to move appropriately. Okay, the muscles may become rigid. Okay, and because of this, movement may get affected. Apart from that, so now these are the prominent symptoms. Apart from this, there are other minor symptoms or the secondary symptoms as they are known as, are also precipitated, like the posture of the person may get affected, that is the way the person stands or sits may be affected. Then the gait, that is the manner in which the person is walking, the person may not able to talk appropriately, okay, or the person may not be able to write properly. Swallowing difficulty also may be seen in such individuals, okay, or the person's totally the mood also may get affected. Okay, with this particular condition, and the person's brain cells also may get affected. So that there are behavioral changes also in such particular person who is suffering from chronic Parkinsonian disease. Then coming to the definition of anti-Parkinsonian drugs, these are the drugs which have therapeutic effectiveness in the disease Parkinsonism or Parkinsonian disease. Okay, and next coming to the classification. The classification is actually divided into two main classes. Okay, that those drugs which are affecting the brain dopaminergic system, and the second class includes the drugs which are affecting the brain cholinergic system. As we have seen that there is imbalance between these two systems. Okay, so under this particular first class, which includes the drugs which are affecting the brain dopaminergic system, and in the introduction I have already told you all that the dopaminergic system is getting depleted over here, or dopamine stores are getting depleted. Okay, so here the drugs will make every possible way to improve the brain dopamine turnover, or say dopamine release, or the availability of dopamine in the brain. So it will improve the brain dopamine levels in this particular class. So there are several subclasses which will help in improving this brain dopamine content, and there are certain drugs which are also used as an add-on therapy also. If you can see in this particular class, the main one is this one, dopamine precursor. The only drug over here is Levodopa or L-Dopa, which is highly effective one, and rest of the classes are mainly used as an add-on therapy to this Levodopa, or sometimes maybe as an alternative therapy. Okay, so mostly other drugs are used in combination with the dopamine precursor, that is Levodopa. We'll see why they are actually combined with this particular agent. Okay, so first class is dopamine precursor including Levodopa, as an example. Second class is peripheral decarboxylase inhibitors. Examples over here are carbidopa and benserazide. The third subclass is dopaminergic agonists. These include bromocriptine, ropinirole and pramipexole. Then the fourth subclass is MAO-B inhibitors. Okay, so here there are specific inhibitors of this subtype MAO-B. MAO enzyme is found in the form of two subtypes, that is MAO-A and MAO-B. So these are MAO-B, specific MAO-B or selective MAO-B inhibitors. Selegiline and rasagiline are the examples. Then the fifth class is COMT inhibitors, that is catechol orthomethyl transferase inhibitors. There are two examples, entacapone and tolcapone. And the next class over here is glutamate antagonist or NMDA receptor antagonist, or they are also known as dopamine facilitator. There is only one example over here, and that is amantadine. Okay, so this is to do with the drugs which are acting on the dopaminergic system, brain dopaminergic system. Then the second main class under the chapter is drugs which are affecting the brain cholinergic system. So here the drugs like anticholinergic drugs, those which are having anticholinergic properties will be used over here. And basically these anticholinergic must act in the brain. So here the site of action should be the brain. So those drugs which are having central anticholinergic properties are only used over here. Not all anticholinergics can be used. Okay, because all the drugs may not effectively cross blood-brain barrier and act into the brain. So certain drugs have higher CNS to periphery ratio action. Okay, so they act more towards the CNS. Okay, so such anticholinergic drugs only are preferred as anti-Parkinsonian drugs because their site is within the brain. Okay, so first subclass under this is central anticholinergics. Okay, examples over here are trihexyphenidyl, this is also known as benzhexol. Procyclidine is the next example, and biparidine is another example. Then second subclass is antihistaminics. Okay, actually these drugs are those which can block the histamine receptor, but though they are antihistaminic, they also have anticholinergic property. Okay, so that's why they are acting centrally, so that's why they are used over here. Orphenadrine and promethazine are the two antihistaminics which can be used as anti-Parkinsonian drugs. So this is to do with the classification. We shall start with the first class, that is dopamine precursor. Okay, only example over here is levodopa or L-dopa, and as I have told that this particular drug is the only one which has high efficacy in the treatment of Parkinson's disease. Okay, so the efficacy of this drug exceeds that of any other drug used alone. Okay, so this is highly efficacious and the first line treatment of Parkinson's disease. This is the accepted short form. PD stands for the Parkinson's disease. Now, why we are using this particular drug? Now this, if you can see, it is a dopamine precursor. Okay, that means this particular drug, it will get metabolized and it will start generating the dopamine in the body after the metabolism. So it's actually a prodrug. Levodopa, it's a prodrug, okay, which will generate dopamine once it is within the body. Now why do we need this formulation of this prodrug? Why can't we give dopamine directly? We know that the brain dopamine is depleted. So why not directly give the dopamine? Now the reason for that is dopamine cannot cross the blood-brain barrier. This is a major drawback because we know that in this condition brain dopamine is depleted mainly. So you need your drug, that is your dopamine over here. It is actually dopamine, it is a catecholamine which naturally occurs in the body. It's a neurotransmitter also which is found in the brain. But when there is depletion in this dopamine in the Parkinson's disease, you cannot give this particular dopamine directly. That's because it cannot cross the blood-brain barrier. That's why it is formulated in the form of a prodrug, that is levodopa, which immediately gets converted into the active form, that is dopamine. Okay, but this levodopa should get activated, or it should get converted to its active metabolite dopamine inside the brain. Once it reaches the brain, it should actually get converted into dopamine. But the major limitation with this particular levodopa is that more than 95% of the oral dose, or whatever drug orally is administered, out of that more than 95% of the drug which has reached your systemic circulation, it will get decarboxylated in the peripheral tissue itself. That is, this activation, decarboxylation, is the process by which levodopa gets converted into dopamine. That is, it is getting converted into its actual active metabolite which is showing the effectiveness. But the problem is that it will get decarboxylated in the peripheral tissue itself. Actually, this activation should occur in the brain, because we are giving it in this form because dopamine cannot cross the blood-brain barrier. So imagine if more than 95% of the drug is getting activated in the peripheral tissue, that is maybe in the gut itself, maybe in your intestine itself is getting activated, or maybe it is getting activated, it is going to the liver and it is getting metabolized and it is getting activated into the liver. So it's getting activated in the periphery, most of it, which is not ideal, because you all know that dopamine cannot cross the blood-brain barrier. So if this activation takes place in the peripheral tissue, periphery meaning outside the brain. Okay, so peripheral activation of this levodopa into dopamine is not advisable. But over here, if you can see, now more than 95% of your levodopa is getting activated in the periphery itself. And whatever is activated, whatever dopamine is activated, it cannot cross the blood-brain barrier. So most of it is getting metabolized, and whatever is remaining, that will start acting on your heart, on your blood vessels and other peripheral organs, maybe on the CTZ, that is chemoreceptor trigger zone, which is responsible for nausea and vomiting. Okay, because CTZ, it is not protected by the blood-brain barrier. So dopamine will easily get access to the CTZ. So this dopamine, once it gets activated into the periphery, it will start acting on the peripheral organs and will start precipitating all the adverse effects or unwanted effects. You wanted it to act in the brain, but it is activated in the periphery and it is acting on the other organs rather than acting on the brain. Okay, if you can see, only 1 to 2% of whatever is administered, only this much amount is able to cross the brain and it will be activated within the brain, and it will get involved, or it will be used as a transmitter. It will be taken up by the dopaminergic neurons. It will be converted into dopamine. It will be stored over there and released as a neurotransmitters as and when required. Okay, but if you can see that there is very less amount which is reaching the actual site of action. That is the main problem with this particular drug. Now we'll see what can be done or how we can solve this particular problem of reaching the site of action. Okay, we'll come to that a little later. Okay, so coming to the pharmacological actions, first and the very important one is on the CNS. Now actually, when levodopa is given to a normal individual, or if the person is suffering from any other kind of neurological condition, it will not show any effect in such individuals. But if you administer this drug to the Parkinsonian disease patient, okay, there will be marked improvement in the symptoms of Parkinson's disease. Now over here, if you can see the symptomatic improvement, out of all the prominent features, we have seen that hypokinesia, rigidity, tremors, these are the most prominent manifestations of Parkinson's disease. So out of these, hypokinesia, that is the low tendency to make any movements. Okay, movements is affected over here. Rigidity. Okay, so here also the person's movement are getting affected. The person's body may become rigid. Okay, so hypokinesia and rigidity, these are resolved first, and later the tremors are also resolved. They are also abolished by this particular drug. Apart from that, secondary symptoms, as I have told under the introduction, posture, that is the way the person is standing, okay, or sitting, the posture of the person, or gait, that is the way the person is walking, the handwriting of the person, speech, facial expressions, mood, self-care, and interest in life, all of these are getting normalized or they are getting improved later on. Okay, so if you can see the overall effects of this levodopa on the person's CNS, they will describe it as general alerting response. Okay, so it will show improvement. Okay, and general alertness is produced in the particular person. Okay, when sometimes problem may be that in certain individuals it may also progress to excitement, frank psychosis. Psychosis like symptoms may also get precipitated. Over here, embarrassingly disproportionate increase in the sexual activity also may be seen in certain individuals. Okay, dementia, if at all it is present, okay, that is effect of your memory and brain functioning. Here there is loss of memory, dementia. Okay, if at all this is present, it cannot be improved by the levodopa. Okay, then there is small description about the types of dopaminergic receptors. DA is the accepted short form for your dopamine. So initially when they were discovered, only two types of dopamine receptors were discovered, that is D1 and D2 subtype. Then later on 3 more receptors were added, subtype of the receptors, that is D3, D4 and D5. And if you can see, all the 5 types of these dopaminergic receptors, D1, D2, D3, D4 and D5, all of these are G protein coupled receptor, GPCR. They fall into GPCR. But basically if you can see, depending upon the transducer mechanisms, okay, or depending upon what is the outcome, they are basically classified into 2 types, that is D1 like and D2 like. Now D1 like receptors include D1 and D5 receptors out of these 5, okay, and these basically are excitatory types of receptors, and the transducer mechanisms followed or the pathway which is followed by these particular receptors, these include increase in the CAMP formation, okay, and PIP2 hydrolysis, because of which there is mobilization of intracellular calcium ions, and also by activating the protein kinase C through IP3-DAG pathway. Then coming to the second type, that is D2 like receptors, these include D2, D3 and D4 receptor, and these are basically inhibitory type of receptors, and these act by inhibiting the adenylyl cyclase. There are multiple mechanisms. First one is by inhibiting the adenylyl cyclase, second is by opening of the potassium channels, and the third one is by depressing the voltage sensitive calcium channels. So this is to do with the dopaminergic receptors through which actually the dopamine is producing its action. Then next, coming to the pharmacological actions on the CVS. Now basically the peripherally formed dopamine, as we have seen under the introduction of levodopa, that more than 95% of the drug will get activated into dopamine, or it will get converted into dopamine into the periphery. So whatever dopamine is formed in the periphery, this will act on the cardiovascular system directly, and it will result in the tachycardia, because they can act on the beta adrenergic receptor. These are catecholamines. Okay, they can act on the beta adrenergic receptors and they will result in tachycardia, that is increase in the heart rate. Apart from this, another action on the CVS is postural hypotension. Okay, so hypotension meaning drop in the BP, and this is actually what is responsible, your posture is responsible over here. Okay, so specifically this will be experienced in the standing position. Okay, so in the standing position the person may experience the hypotension or dizziness or giddiness may also be seen in certain individuals. So this hypotension, postural hypotension, this is mainly precipitated. The reason for this is actually the central action, not the direct action. Okay, so whatever dopamine and noradrenaline is formed in the brain, these can decrease the sympathetic outflow. Sympathetic outflow or your adrenergic system, okay, which is originating from your brain, which can supply to the peripheral organs or to your cardiovascular system. So here the sympathetic outflow or the adrenergic system, this activity of the adrenergic system or the sympathetic outflow is decreased. Okay, and sympathetic outflow, the action of sympathetic outflow on the heart, you are aware of that it results in hypertension. It acts on the blood vessels also. Okay, vasoconstriction is produced, because of which the blood pressure increases. So that's how, by decreasing the sympathetic outflow, it will result in hypotension. Apart from that, the dopamine which is formed in autonomic ganglia, these will result in decrease in the ganglionic transmission, which will again be responsible for the postural hypotension. The next is action on the CTZ, that is chemoreceptor trigger zone. As I have already told you all that this is not protected by the blood-brain barrier. So whatever dopamine is formed in the periphery, it can easily gain access to the CTZ, on which the dopaminergic receptors are present. Okay, and these are excitatory type of receptors. Okay, so because of action of dopamine on the receptors in CTZ, it will result in nausea and vomiting. Okay, because peripherally formed dopamine can get easy access to the CTZ, as it is not protected by the blood-brain barrier, and it will start producing nausea and vomiting. Okay, nauseated feeling will be seen, or vomiting also may be precipitated in certain cases. However, this particular action may fade off as you continue the treatment. Tolerance will be developed to this particular action. So nausea and vomiting will be seen at the initiation of the therapy. When you start the treatment, nausea and vomiting will be seen, but later on it may fade off. The next action is on the endocrine system. Dopamine, it acts on the pituitary gland, basically on the mammotropes. Okay, it will result in inhibition of the prolactin release, and on the somatotropes it will have action like it will increase the growth hormone release. So hormonal imbalance is also possible with the levodopa. So this is to do with the pharmacological actions. Coming to the pharmacokinetics. Okay, if you consider the absorption, it is rapidly absorbed from the small intestine. Okay, so absorption will again depend upon the gastric emptying. So faster the gastric emptying, better will be the absorption of the levodopa. Another factor responsible for absorption is the transporter. It requires transporters for it to get absorbed. So it is absorbed with the help of specialized transporters, which are actually meant for absorption of aromatic type of amino acids. So those transporters, active transporters, which are responsible for absorption of aromatic amino acids in your intestines, the same transporter is also used by levodopa for its absorption. So there are certain factors which can affect the bioavailability of levodopa. That is, how much of levodopa which is administered will reach your systemic circulation. It is governed by two main factors. First one is the gastric emptying. As I have told you all that mainly it is getting absorbed from the small intestine. So faster the gastric emptying, better will be the absorption. So also slow gastric emptying will expose your levodopa to most of the degrading processes in your GIT. So it will get metabolized in the GIT, in the gut wall itself. It will get metabolized, it may get activated, and less of it will be available to cross the blood-brain barrier. Okay, so gastric emptying is an important factor which can govern the bioavailability of levodopa. Another factor is the presence of amino acids in your food. Okay, so if you consume food which contains amino acids, okay, so amino acid transporter is also utilized by levodopa for its absorption. That's what we have seen over here. It is utilizing the active transport which is meant for absorption of the aromatic amino acids. So in case if the food which you are consuming along with levodopa, if it contains amino acid, then obviously there will be a competition between these amino acids and levodopa for the same carrier, and because of which the absorption of levodopa may get affected. So as far as possible, it should not be taken with meals, especially those which contains the amino acid. Okay, then if you can consider the metabolism, the first pass metabolism also is very high with this particular drug. So in the GI tract itself, in the GI mucosa itself, it can get metabolized, or even it can get metabolized into the liver before it can reach the systemic circulation. First pass metabolism meaning metabolism which takes place before the drug reaches the systemic circulation. Okay, so it will get metabolized, it will get activated, so more of it will get activated in the periphery, in the gut wall or in the liver, and less of it will be available to cross the blood-brain barrier. Now, coming to the metabolic pathway. So, what are the actual processes by which this drug is getting metabolized? This is a very important part. If you can understand this better, further classes also can be understood very well from this. The mechanism of action of the further classes also will be better understood with this particular process. Okay, so this is very important, the metabolism of levodopa, how exactly it is getting metabolized. Now here the activation process is also discussed and the other processes of metabolism are also discussed. Okay, now let's see what exactly is happening. So before going to the actual pathways of metabolism, let me briefly describe what exactly this particular thing written in this box and what is written in this particular box. Okay, so it depends upon where exactly the metabolism of your levodopa is taking place. You can see that this particular process is what is taking place in the periphery, that is outside your brain. Once maybe it is in the GI tract itself before its absorption, or maybe in the liver, or maybe in the other organs, or maybe once it is inside the blood. Okay, once it is absorbed. Okay, so this is what is happening in the periphery, and these are the metabolic processes which are taking place inside the brain once it reaches your brain. Okay, so here is your drug which you are talking about, levodopa. Now levodopa, actually it should act in the brain, it should reach the brain, that's where exactly it should get activated, and then it will start producing its action. But as we have discussed in the introduction, that this levodopa, it will get activated into dopamine in the periphery itself, so that less of it is available to cross the blood-brain barrier. Just 1 to 2% of your levodopa can reach the brain. It can reach it can cross the blood-brain barrier, because most of it, more than 95% of your levodopa has got converted into dopamine, or it has got activated in the periphery itself. That's a major drawback with this levodopa. Okay, so if you can see in the periphery, there are two pathways by which the levodopa will get metabolized. One is the activation process, because it's actually a precursor of dopamine. So the activation, that is conversion of levodopa into its active metabolite, that is dopamine, it requires this enzyme DDC. DDC is the enzyme dopa decarboxylase. This is a very important enzyme required for the activation of levodopa into its active metabolite. Okay, so dopa decarboxylase converts levodopa into its active metabolite, that is dopamine. Same process is also taking place in the brain. Levodopa gets activated into dopamine by utilizing dopa decarboxylase. So this enzyme is present in the brain as well as in the periphery. So in the periphery also it can act on this levodopa and activate it into dopamine. But dopamine, as I have already told you all, that dopamine cannot cross the blood-brain barrier. Okay, so if it is getting activated over here, it is not good. It will result in decrease in efficacy of this drug. This drug will not show effectiveness, because very less is available to cross the blood-brain barrier. So this is one of the process which is taking place in the periphery. And the second mechanism by which it is getting, or second pathway by which it is getting metabolized, is with the action of this enzyme COMT, that is catechol orthomethyl transferase. So levodopa can also be acted upon by this enzyme, and it will get converted into 3-OMD, that is 3-orthomethyl dopa. This is an inactive metabolite which is generated. Okay, this does not have any anti-Parkinsonian action. It is only dopamine which is producing the anti-Parkinsonian action, and that too dopamine which is formed in the brain, not in the periphery. It will start producing adverse effect. It will have action on the other systems of the body, specifically the CVS. Okay, so these are the two main processes by which the levodopa is getting metabolized, and the same process is also taking place in the brain also. Levodopa in the brain can also be acted upon by COMT, and it will get converted into 3-orthomethyl dopa. So these are the two processes or pathways by which the levodopa can get metabolized, out of which one is responsible for production of the active metabolic, and that too the one which is formed in the brain is important for us, because brain is the site of action where exactly your dopamine must be active. However, the problem of this drug is peripheral activation of this particular drug takes place. Okay, let's see how it can be prevented. Okay, now further, dopamine also is getting metabolized. Okay, whatever dopamine is formed, that also is getting acted upon by two enzymes basically. One is the COMT, that is catechol orthomethyl transferase, and the second enzyme is MAO-B, that is monoamine oxidase B. As I have told you that there are two types of these enzymes, MAO-A and MAO-B, out of which specifically MAO-B is the enzyme which is responsible for metabolism of this dopamine. Now, final product which is formed by metabolism of dopamine is homovanillic acid, HVA, that is homovanillic acid. But the intermediate which is formed, it depends upon which enzyme is acting first on the dopamine. Now actually final product remains the same. There are two pathways by which this dopamine can get converted into homovanillic acid. Okay, one is this one and one is this one. Okay, so intermediates, if you can see that they are different. Here it is 3-MT, that is 3-methoxytyramine, and if it is following this pathway, the intermediate which is formed is DOPAC, that is 3,4-dihydroxyphenyl acetic acid. Okay, but the final product is same, that is homovanillic acid. But intermediate which is formed, it depends upon which enzyme is acting first on dopamine. Both the enzymes are responsible. Okay, first, if COMT acts on dopamine, it will result in formation of 3-methoxytyramine. Further, this 3-methoxytyramine will be acted upon by MAO-B and it will get converted into homovanillic acid. Now, supposing if dopamine is first acted upon by MAO-B enzyme, then it will result in formation of DOPAC, that is 3,4-dihydroxyphenyl acetic acid. Further, this DOPAC will be acted upon by COMT enzyme, catechol orthomethyl transferase, and it will ultimately get converted into homovanillic acid. Alright, so this is the metabolic pathway of levodopa and dopamine. Now, in this particular picture, there is something which is shown in pink color. Please. Okay. So, if you can remember, these names were in the classification, right? Tolcapone, entocapone. These are the drugs which can inhibit this enzyme COMT inhibitors. And carbidopa and benzaldehyde. These are peripheral decarboxylase inhibitors. Peripheral meaning they can inhibit this enzyme only in the periphery. Can you see this over here? No, it cannot inhibit this enzyme inside the brain, but it can inhibit this enzyme in the periphery. So they are selectively acting or they are selectively inhibiting this enzyme in the periphery. Whereas over here tolcapone and entacapone can inhibit the enzyme COMT in the periphery, whereas only tolcapone can inhibit this enzyme in the brain over here and here. Okay. Apart from that, salicylic also we have come across. MAO-B inhibitor, a selective MAO-B inhibitor. This can inhibit MAO-B enzyme which is responsible for the metabolism of dopamine. Okay, so this is to do with the metabolic pathway of levodopa and dopamine. As I have already told you all, only 1% of the drug will cross the blood-brain barrier and it will be available for the action. Plasma T half-life, the levodopa is very short. Within 1 to 2 hours it will get converted into dopamine. Now this is again one more important factor which you should keep in mind, that for the action of the enzyme dopa decarboxylase, okay, a cofactor is required. Pyridoxal is acting as a cofactor for the action of this particular enzyme. Okay, and the metabolites which are found after the metabolism of levodopa and dopamine, they are mostly excreted in the urine after the conjugation. The next part is the adverse effects. Coming to the adverse effects of levodopa. Now, actually, there are many side effects of levodopa. They are quite frequent and sometimes they are quite troublesome. Okay, some of the side effects, these are dose related. Okay, that is, in case if you start at a lower dose, you can subside these adverse effects, or you can reduce the severity by starting at the lower doses. Okay, then side effects also depend upon certain which occur at the beginning of the therapy. Once you start the therapy, certain adverse effect will be produced at the initiation of the therapy, and there are certain side effects which are seen later on, maybe years after continuation of the therapy. So adverse effects are basically divided into two. Okay, those which are seen at the initiation of the therapy, that is when you start the therapy, at the beginning of the therapy. Okay, and these side effects which occur at the initiation of the therapy, this can be minimized by starting at the lower dose. All these can be minimized by starting at a lower dose. So initially you can give a low dose and gradually you can go on increasing the dose up to whatever therapeutic dose is required by that particular person. Okay, so coming to the adverse effects which are seen at the initiation of the therapy. Okay, these include nausea and vomiting. As we have already seen that under the actions that CTZ, it is not protected by blood-brain barrier. So whatever dopamine is formed in the periphery, it can gain access to this CTZ and it will start producing nausea and vomiting. Okay, but once the treatment is continued, tolerance is developed to this particular action. Okay, next adverse effect is postural hypotension. This also we have seen under the actions on the CVS. This is seen almost in the 1/3 of the patients. Okay, and certain patients may also experience dizziness, fainting, giddiness may be seen, or certain people may also faint, okay, because of the postural hypotension. Then other side effects include cardiac arrhythmias, exacerbation of angina. Okay, so arrhythmias may be precipitated, or angina may be become more severe. Attacks of angina also may be precipitated. That's because of the peripherally formed dopamine. So whatever levodopa is converted into dopamine in the periphery, this can act on the beta adrenergic receptors, as I've told you already under the actions. Okay, so especially those people who are suffering from some kind of heart disease, or maybe those who are already suffering from arrhythmias or angina. So such individuals are at more risk of precipitation of these adverse effects. So it's better to avoid such drug or levodopa in such patients, or if at all it is unavoidable, you have to be little bit cautious, or you should monitor the patient for precipitation of these conditions. Okay, then another minor effect is alteration of the taste sensation may be seen. Okay, so these are the adverse effects which are seen at the initiation of this therapy. Then after prolonged therapy, that is if you continue this treatment, because Parkinson's disease it requires a prolonged treatment, or it's a chronic condition. So prolonged treatment is required. So after prolonged therapy, certain side effects may be precipitated. Among this, prominent one is dyskinesia, that is there are abnormal movements. Okay, so these abnormal movements, these include facial tics. Okay, so facial tics meaning maybe there is involuntary blinking of the eyes sometimes. Okay, so these involuntary facial movements may be seen in certain individuals. A person is not doing it purposefully. Okay, but it is involuntary in nature, and sometimes it can be controlled also. And then grimacing is another expression, facial expression, wherein as if the person is in the severe pain. So that kind of expressions may be seen. Okay, then next is the abnormal movement is tongue thrusting. This is the forceful pushing of the tongue out of your mouth, okay, in between your teeth. Then chorioathetoid movement of the limb. This is the abnormal movement of the limbs, maybe your legs. So such abnormal movements or dyskinesia may be precipitated after prolonged treatment. So these are quite disturbing to the patient. The next is the behavioral effects. So here mild effects like anxiety or nightmares, that is bad dreams, may be seen, or sometimes it may also be precipitated in the form of severe behavioral effects also, like depression may be precipitated, mania, that is irritable mood, may be seen, hallucinations, that is imagining or hearing something which is not there or it does not exist, or seeing something which is not existing. Mental confusion may be produced, or frank psychosis may also be precipitated sometimes. Another problem, the major problem, is fluctuation in the motor performance. Okay, so that is, supposing if you continue the treatment over the period of years, so 2 to 5 years, later on there may be fluctuations in the motor control. So whatever motor functions are improved, okay, whatever symptomatic improvement which is shown in these Parkinsonian patients, these may get affected, so that fluctuations in these motor controls may be seen. That is, sometimes switches or on-off type of symptoms may be seen. That is, the motor functions may be improved sometimes, and the motor functions may be deteriorated. On meaning motor functions are improved. Off meaning the motor functions are again impaired. So sometimes even all or none type of response is also seen. That is, the patient sometimes may be very well, show total improvement, and sometimes the patient may be again disabled. So as if the levodopa is not showing action. Okay, so switches or on-off or all or none type of responses are seen with the prolonged treatment of levodopa. Apart from that, you should also be cautious while administering this drug into elderly or patients who are suffering from ischemic heart disease, or those who are suffering from cerebrovascular or psychiatric or hepatic or renal diseases, or those who are suffering from peptic ulcer disease or glaucoma, or the patients who are suffering from gout. You should be careful, otherwise adverse effects may be precipitated or the conditions may be worsened in these particular patients. Then next, coming to the interactions, the drug interactions when you administer this drug along with other kind of drugs. Now the first interaction is with the pyridoxine. If you can remember that pyridoxine is a cofactor for dopa decarboxylase. This was a point which I had told you all under the pharmacokinetics. That pyridoxine, it is acting as a cofactor for the enzyme decarboxylase. Okay, dopa decarboxylase. Dopa decarboxylase is the enzyme which is responsible for conversion of levodopa into dopamine. That is, activation of levodopa takes place with the help of dopa decarboxylase, and for this enzyme pyridoxine is acting as a cofactor. Now if this pyridoxine is present, it will start enhancing the action of the peripheral dopa decarboxylase enzyme, so that the peripheral decarboxylation of your levodopa will be enhanced. Okay, so that is, the activation of levodopa in the periphery will be enhanced, because of which less of levodopa will be available to cross the blood-brain barrier. As we have seen that it should act in the brain, not in the periphery. Okay, so it should get activated in the brain, not in the periphery. But here, if pyridoxine is present, more of levodopa will get activated into dopamine in the periphery itself, and less of it will be available to cross the blood-brain barrier and to actually reach its site of action. Okay, so avoid this pyridoxine. Okay, in case of levodopa. Then other drugs which can affect the action of levodopa are phenothiazine, butyrophenones, metoclopramide. Okay, these are used in the treatment of the psychosis. Okay, antipsychotic drugs. So these basically act by blocking the dopaminergic receptor. These are dopaminergic receptor blocking agents. So in case of levodopa, it will get converted into dopamine. Dopamine will act as a transmitter, it will get released, it will act on its receptor, that is dopaminergic receptor, and that's how it will start producing improvement in the Parkinson's disease. Okay, but these drugs, act by blocking the dopaminergic receptor. Okay, so that's how they are producing their therapeutic effect. Okay, but when these drugs are combined with levodopa, it will, or they will block the dopaminergic receptor, so that the dopamine which is formed from the levodopa will not be able to bind to its receptor and it will not show effectiveness. So these drugs can reverse the therapeutic effect of levodopa by blocking the dopaminergic receptors. Apart from that, there is one more drug, domperidone. Okay, now this particular drug also acts by blocking the dopaminergic receptor. Okay, so it acts on basically by inhibiting the nausea and vomiting. Okay, this particular drug. So it can it can inhibit the nausea and vomiting, which is produced by levodopa. And that levodopa action on the CTZ, we have seen that it can gain access to the CTZ and it can induce the nausea and vomiting. So how this drug will interact with levodopa? It can only block the nausea and vomiting which is produced by the levodopa. Okay, since this drug also cannot cross the blood-brain barrier, it will not affect the action of levodopa in the brain, but only in the CTZ it can block the nausea and vomiting which will be induced by the levodopa. So only the adverse effect is blocked by this particular drug, not the therapeutic effect. Then one more drug, that is reserpine. This can also abolish or diminish the action of levodopa by preventing the entry of dopamine into the synaptic vesicles, where exactly this the dopamine which is formed from the levodopa, it will be taken up by the dopaminergic neurons and it will be stored in the synaptic vesicles. Okay, and it will be released as and when required. So reserpine, what it does is it depletes it from the synaptic vesicles. Okay, so that it is not available for the transmission. So better avoid reserpine with levodopa. Then another interaction is with the non-selective MAO inhibitors. If you can remember in the classification, there is MAO-B inhibitors, which will inhibit the enzyme MAO-B responsible for metabolism of dopamine. But if you give a drug which is non-selective in inhibiting this enzyme, which means that these drugs, these non-selective MAO inhibitors, can inhibit MAO-A as well as MAO-B. Okay, so such drugs, if they are given, they will prevent the degradation of peripherally activated dopamine and noradrenaline. Okay, so whatever dopamine is formed from the levodopa in the periphery, okay, so that will not be further metabolized. So dopamine levels will be very high, it will remain high, and it can act on the CVS and will start precipitating hypertensive crisis, because it acts on the beta receptors and it can result in the tachycardia and even hypertension also. Okay, so hypertensive crisis may be seen if non-selective MAO inhibitors are combined with the levodopa. Then another interaction is with the antihypertensives. Okay, those drugs which are used to reduce the blood pressure. So when these drugs are combined with levodopa, postural hypotension is accentuated. That is, it is enhanced. This particular adverse effect we have seen, postural hypotension, which is seen at the initiation of the therapy. Okay, so if a antihypertensive drug is combined with levodopa, this particular adverse effect may be enhanced. So in that case, you need to reduce the dose of these antihypertensive drugs. If at all, you have to give levodopa in those patients who are already taking antihypertensive drug. Okay. Another interaction is with atropine and other type of anticholinergic drug. Now, if you can remember the classification, the last class, that is the second main class was centrally acting the anticholinergic drug. The first subclass in the second class of the drugs which are acting on the in the Parkinson's disease. Okay, that is drugs which are acting on the brain cholinergic system. Under that, we have seen that centrally acting anticholinergic drugs are actually utilized in the treatment of Parkinson's disease. Okay, so if you can give these anticholinergic drugs along with levodopa, obviously there will be additive anti-Parkinsonian action which will be shown when they are, both of them are combined. Okay, that is low doses of levodopa, if they are combined with anticholinergic drug, obviously they will show additive effect. Okay, so it will help in reduction of the dose of the levodopa also. But one more problem with these anticholinergic drugs is that they also retard the absorption of the levodopa. Okay, because they are affecting the GI motility. They are decreasing the GI motility. That's how levodopa will not be able to get absorbed appropriately, and more time is available for its peripheral degradation. That is, in the periphery it will get converted into dopamine, and less of it will be available to cross the blood-brain barrier, and the efficacy of levodopa may be reduced. Okay, so this is how it is interacting. One is a intentional interaction, that is to show the additive anti-Parkinsonian action. The centrally acting anticholinergic drug can be combined with levodopa, but at the same time anticholinergic drugs can also retard the absorption of levodopa, so that the effectiveness of levodopa itself may go down. So these are the interactions of levodopa.